Today, we share part 2 of our sit down with Dr. Ahmad Garrett-Price of GP Health on the impact of bias and churn and burn on the healthcare system. This part focuses on advocacy. He shares his advice on how to interact with medical professionals to get the best possible care for ourselves and our loved ones. This is an episode you'll want to save and share for when you need it. Enjoy. Moving more into advocacy piece, how can you get doctors to humanize you since there is this churn and burn? And the model is like, I've got to see at least 20 patients a day just to be profitable. Like, how can I make sure that I'm getting the best? What are things that people can do to stand out to doctors without being boisterous?
I like when people come engage me in a collaborative manner, because that's really what it's about. Even if you look at the data, that's usually when the best result is achieved. Humanize that interaction to a certain degree. Like, when you come in, have a 2 to 3 minute conversation, probably not even about what we're here to talk about. I actually do that. That's kind of my style as a physician. How's your day? How you been? Etc. Physician will appreciate that. So that's one thing. But I think in general, this term of, and I keep going out and not saying activated patient. And what I mean by that is just, have a sense of maybe what you want to accomplish in that visit, and not necessarily these, I got 100 questions, but just questions to keep, that engagement level high. And again, there's good data out there that says that when you are presenting yourself that way, you can start to, if there is bias in that room against you, you can start to disrupt that. So I think in general, self-care, come, even if it's just one question, just come with a question about your own health and well-being. Humanize that reaction also on the other end, because empathy is a two-way street. Because a lot of times, and I'm just telling you, there's a reason I moved out of that system. Like, a lot of the time, it's like, I can't tell you how much I appreciate when it's like, hey man, thank you for taking time out today, or thanks for talking to me, and thanks for, my style has always been kind of long-winded if you can't tell, but it makes my day as a physician when somebody asks me how I'm doing to a certain degree. It doesn't make like, oh, they're going to get the best care. Everybody to me is getting the best care, but it really is helpful for me as a human being. So empathy is a two-way street. And on our side of things, we have to do better with that as well. We have to all treat each other as humans to a certain degree. Like, I actually think we need a better word than patient. Yeah. Like, I don't necessarily call patients anymore. Okay. You know what I mean? Just things like that, like Mr. Curry. I don't know your last name, Jesse, but you know what I mean? Like, things like that, just little human touches, if you will. Not necessarily clinical touches, human touches will help you rise above that. Because even as a Black man, not every patient that I see agrees or may look at me. Yeah. That's another thing we want to talk about. How do I get treated on the other end of that? Sometimes not very well. I've been called all out my name, and I'm a whole ass doctor. Yeah. So, but human touches. Human touches, I guess, is what I'm saying. Yeah. So
the human touch goes a long way in terms of getting that doctor to kind of open up and just, hey, I'm really, appreciative and thankful. At the same time, whenever you do have to, I feel like, step on the gas a little bit and apply some pressure, just because you have applied that human touch before, I think it softens it just a little bit. And then you can say, hey, I'm just trying to partner here with you. But you've got to give me something to work with. And I say that because I think in one of the instances with my mom's care, and this is something that doctors were telling me, which I found was really fascinating, that every single person that I spoke with, even the nurses there, they pulled me aside and they said, you've got to be the best advocate for your mom, for her health care, including the nurses that were there in the various hospitals. They're like, you need to go ahead and speak up. You've got to ask these questions for these doctors. You've got to be in their face. This is coming from the medical staff, right? So please and thank you went a long way. But when I had to, like, hey, I've asked for this like 3 times. We've been waiting around for this. I didn't have as much what's it called? I didn't have as much uneasiness doing that because I had said, all right, Linda, I ain't already asked you about your day now. I ain't heard about your kids. Yeah. Listen, if you don't get this IV up here that we didn't ask for like 4 times now, and so I do think that it actually helps out a little bit because they can kind of maybe see that, hey, you're human too, and you got stuff going on. And I'll preface it with like, I can't imagine what you have going on. You're doing all these different rooms. I even said, is there someone that I can call to go and do this? Because I'm willing to go and do that because you've just got a lot going on. That woman that you're standing over, she means something to people. She's got grandchildren. She's got children. She's got a brother. She's got nieces and whatnot. So she matters to people. All right. And I know that you may not know that because you're just not meeting her, but we need the best possible care. We need her to get back at parity.
Right. I think that was a great approach, by the way. Humanize, but then also be very, I think you used the word firm, but firm in what you want and clear about communicating that to the staff. And it does take, unfortunately, consistent engagement with that care team. I actually had a conversation last week with my family. I had a distant uncle who was in peril in East Texas, and they called me because they weren't getting what they want. And so I have become, friends, family. I advocate for a lot of people kind of silently outside of even formal structures. And we had a talk kind of about that. It's like, well, this is how this should work, and this is what we're going to do. And I told him, we're going to call a care meeting, and we're going to say, hey, much like what you said, like, hey, we love our loved one, and we are trying to get the best outcome. How can we do that with you? Right? And we went over different terms and kind of lingo to a certain degree. But they said after that, they had such a peace and comfort about what was going on, and they noticed a change in the healthcare, and they got a good response, and it put everybody at ease. I should also take this moment to remember him because he passed away this week. Rest in peace, Jerome Middlebrook. So these are real scenarios.
Yeah.
And I should say in the background, I'm always doing things like that and dealing with real scenarios. But it brought a certain level of ease and comfort on both sides of the equation, which I'm going to just say that as a hard fact. Anytime you have a loved one in an inpatient scenario, inpatient being in the hospital, outpatient outside of the hospital, you want to have regular care plan meetings with that team. And that team, and I'm just giving the game, if you will, there's usually a attending physician and then a nurse and then the staff kind of executing the plan. You want to say, hey, we want to meet with this care team on a semi-routine basis, or have someone communicating with us. And usually maybe you assign a family member. I always think it's good for families to have presence in hospital. Right. I am not naive. I know that is not always the case. And even when I see it myself, it breaks my heart when I see somebody in very critical condition. There's no family close by, because I understand that things could fall through the cracks. I would say just a hard fact is important. And during those care meetings, you want to understand what the plan is, the why of the plan, the outcome of the plan, and the desired goal of the plan. But you also, in my mind, like as a physician, I keep what I call a differential. So you better believe there's a plan A, B, C, and D. You kind of want to understand why B through D are also not being chosen. Yeah. Again, a lot to take on sometimes as a family in a acute situation, but I'm just reporting from the other side on this one. And what I'm saying, like, those are the things that I have seen get you to a better place to a certain degree. Should you always have to do those things? Heck no. Yeah. Right? Should we have to go in and self-advocate? Heck no. But the alternative, right, it let these things be up to chance, I can't live with.
Yeah.
So no, it's not the ideal scenario. And it kind of, again, goes back to designing for a better interaction and outcome and experience, right? Because I think also there's a large distrust of these structures because a lot of folks, we talk about our Latino brothers and sisters, LGBTQ community, we talk about African Americans, blacks, and we just had poor experiences with this structure. So there's a lot to be said for that, and there's a lot of repair that needs to be done here.
Yeah.
Yeah. And as it is in medicine, I mean, there are other facets of society in the world that I feel like this can apply to as well.
Yeah.
You know, as you're talking about this like collaborative approach to healthcare and to patient care, it reminds me too of some of the reforms that have been with like policing, and having a much more collaborative approach to ensuring people's safety in neighborhoods by building those different rapports. It just stinks though. If I can just call it out, you know, to say this it stinks though that this is one of the most costly things. People have lost their livelihoods. People have ruined their credit. People have gone into bankruptcy. People have lost everything over healthcare for a system that is in many ways, I feel like, designed not to help them. Yeah. It's designed like in every possible way not to get them the help that they truly do really need unless they actually are advocating for it. And I know that's really, it sounds like pretty cynical, but that it's just the way that I feel once you look at.
You are on point with that. That's why doctors and nurses who got into this, like, look at me, look no further than me. I understand that about my own industry. So it was a sacrifice. I'm not getting that check anymore. But that's why I can no longer be in this.
Yeah.
You know what I mean? You know what the number one cause of bankruptcy in this country is?
What is it? Tell people.
Healthcare bills.
Yeah, I know.
2/3 of that being blacks, African Americans. Healthcare is probably one of the biggest wealth transfers we don't ever talk about, ever. You're right, it's expensive, but the outcomes are the worst.
Right.
Some of the worst in the world, because the expenses caused by the diabetes when you go in and we have $100,000 visit, whereas if we would have just said, hey, let's eat a little better, let's do this, let's do that, which, by the way, these very basic things that are cheap and inexpensive are not paid for. I will cut your leg off, though, when it gets bad, and I'm going to charge you a ton for that. Yeah. That is the U.S. healthcare system in a nutshell.
Right.
Where we're disease and procedural focused, can't help you if that's not what it is. And that's where the cost comes from, because we let people get very sick, and now they need very expensive medications. They need very expensive care. And to a certain degree, we keep you in that cycle, right, until the outcomes becomes poor, because that's just the design. I keep going back to this thing. This is the design. So to your point, it's a great call out, because it's just not, this is supposed to be one of the most foremost structures to our society, and it operates in this way. So there's heavy reframing of how we approach these things needed. And one other thing I should also say is that part of when I talk about U.S. healthcare education, a lot of it is geared towards specialization.
Right.
So you're encouraged, like when I wanted to be a family doc, it was like, why? You need to go do cardiology, be a surgeon, do these things. But we need more of our talent also, and our empathetic talent, staying on the front line, if you will, so everyday people can interact with that brilliance and level of empathy. So just a lot of reframing.
Right. Yeah. If people don't feel that they're getting the help that they need or the quality healthcare that they think that they are deserved, what can they do?
And so when you're in these inpatient settings, there's always a charge nurse, right? There's always an administrator there. There's always a kind of chief of that department. And you can just really go down to hospital administration and raise the concern right there. So that's one thing. And and I also like to say, kind of put things in writing to a certain degree. So we're big on documentation in medicine, so you can have a trail. And now on the outpatient basis, I would say that it's the same thing to a certain degree, you know, kind of understanding the quote unquote leadership structure there. but you can always move past that level that you're in. So I think of nurse administrators, I think of like chief medical officers, and I think of going directly to that administrator at that particular facility, I guess, to actually raise the level. Or you could tell the doctor themselves that you're concerned, honestly, about what's going on here.
Can I just say that is 1000% true?
Mm,
A doctor put me onto some game a long time ago, and I used it recently with my mom. But I was waiting in the emergency room for like 8 hours, just
mm-hmm,
trying to get help, and I had insurance, and I had a nasty stomach bug. I had just been, vomiting and going out both ends for a minute. Was pretty dehydrated. I
mm,
felt terrible. Of course, was it life threatening? Not really sure. Probably not, right? But I was sick like nonetheless. And I just been sitting there like just 5 more minutes, and that turned into 8 hours,
wow.
just sitting there. And so I called a doctor and I was like, "Is there anything that I can do?" She said, "Walk up to that nursing station." She was on the phone with me, and she said, "I want you to just to let you know, repeat this." She said, "Hi, I've been sitting here for 8 hours. I have insurance, and I've been told that you're gonna go ahead and see me, and I need to see a doctor right now because I'm really concerned about the overall quality of the healthcare that I'm receiving." Just like that, I repeated just that same thing. I was seen in 10 minutes. I was put into a room and seen in 10 minutes. And it just goes to show that, like, whenever you call something out like that, and whenever you say like certain buzzwords like quality of care, same thing like with my mom. Whenever I said we're just concerned about the overall quality of care, all of a sudden I wasn't talking to the attending, I was talking to the actual
Mm-hmm.
doctor for the entire, rotation or whatever they're called,
Chief, yeah.
the chief doctor. All of a sudden, the administration was coming to meet with us
Mm-hmm.
when you say those certain things. And these aren't threats. It actually was the actual truth.
Actual concern.
Is it, but all of a sudden you've got this elevated response and things are being put in motion. And I just have to think, just, why wasn't that done from jump? Why do we have to get to the point where it's almost got to become contentious for you to go and do anything?
Mm-hmm.
And that's the cynical viewpoint that I have of healthcare. It's got to be critical. We've got to be in the red for you to go ahead and move, which it sucks because then no one's really getting healthy. All we're doing is just responding to the house fire.
Yeah.
Like what if we could, whenever we smell smoke, we can call the fire department to come out.
Mm-hmm.
Fire department in this scenario is not going to come until they actually see flames on the house.
Mm-hmm.
But I told you there was smoke an hour ago.
Right.
So, but in that sense, though, people are getting worse
Yeah. Yeah.
until you ring those alarm bells, and that's wild to me. But that is absolutely 100% true advice. If you use some of those words like that, the quality of healthcare,
Mm-hmm.
your experience changes just like that.
Immediately.
Mm.
You're exactly right. I've seen it. And that's why I said, I was like, yeah, like it may sound counterintuitive, but just say that directly. Like, look, I'm concerned about what's going on here, quality of care. I'm not getting the best care. Folks will spring into
Yeah.
action. And to your point, we shouldn't have to do it. And remember how I said we keep you in this pattern, like
Mm-hmm.
when you're sick. And so it's the same ethos, right? It's the
Right.
same thing. So
What's a misconception that people have of doctors in your in in your position? Like, I know that I have my viewpoints and the way that I feel based off of what I've experienced. What's a misconception though that people like me have of you and your position?
there's doctor and there's patient. And I wish people could see how many barriers are actually between us. Even
Mm-hmm.
though we may be physically sitting in a room, you should understand there are so many barriers between me and you having this very therapeutic, healthy relationship. And a lot of it has nothing to do, like when insurance contracts are negotiated, when I was in insurance, you think I'm in the room negotiating these contracts? I was kind of told.
Yeah.
You know what I mean? You think I'm in a room negotiating quality metrics? No. And a lot of these things are dictated by people who don't see patients. Think about that. Your care is probably dictated by somebody who's never seen a patient.
Mm-hmm.
And the insurance company saying, oh, we don't cover this, is that person making that call probably never seen a patient. You see what I'm saying? And so I think just for me, I try to be empathetic and give, but is that folks don't want to do the right thing. A lot of times you do, and that's why you see a mass migration out of this profession, because there has been the term that has been used in my community is moral damage. Hell, I want to do the right thing, but the structure that I'm a part of makes it very hard for us to achieve the
Mm-hmm.
best outcome, to the point that, you know what? I don't want to do this anymore.
Mm-hmm.
Yeah. And you should also know that we're facing an extreme doctor shortage. Like the year 2030, we're going to be like 100,000, 130,000. So we're at this kind of crises moment if people don't understand and recognize, like, the pandemic was sort of a warm up here.
Mm.
Like it could get shaky here. And it's not to build fear or distrust, but I'm just saying that's the real thing. And that was before doctors and nurses started leaving in droves, because
Right.
we too felt underappreciated. Like, okay, you want me to frontline care for a disease I don't know anything about. This is when it first started, I didn't have any PPE. And we're just talking about in general. Yet now that you're in financial turmoil, I'm the highest paid employee, so I'm gonna get cut. That call comes from the ivory tower from you on the front line. Imagine how you feel. Because otherwise, you can't continue in that system. And there's a lot of us who just feel very downtrodden and really down on our luck. And it may seem weird, like, oh, doctors are making all this. It's like, nah, a lot of us don't feel great. The
Yeah.
suicide rate amongst doctors is twice as much as the general population. I'm gonna tell you this. I have not worked at a healthcare organization where I haven't lost a colleague to suicide.
Mm.
Think about that. You go to work and somebody that you're working with takes their own life, and it happens routinely. I think the physician suicide rate is twice that the normal population,
Mm-hmm.
because you're just so injured in a lot of ways, morally, physically, mentally, spiritually. You go home knowing that, man, you're kind of fighting with your eyes closed a lot of time. It's just like,
Mm-hmm.
all right.
I imagine it's pretty difficult when you think about what happened in 2020, and you go from being the hero to the villain
Some sort of
in a
villain.
matter of
Days.
months,
Yeah.
days, really.
Days, months. Yeah. It was
And
just,
like everything about you and your profession is questioned, and your intentions, and so you're fighting with that too. Like
yeah.
why? And so when you add that element in there, just from the patients, you're already getting that probably from that insurance company. Like, do they really need this? Are you really sure this is not? No, I think that they don't really need this surgery. And then you also have patients question that too. And like, you know what? Screw it. You do what you need to do. Tell me what you want.
Mm-hmm.
And so pretty soon it's like, I think that we are back here at square one, which is why I do think there is hope in
There's
that,
definitely hope.
in this example, that you gave, humanizing yourself and showing that you actually want to partner with that doctor. It actually kind of lowers that barrier so that they can see, all right, this person's actually pretty genuine. They'll actually listen to me. And we can collaborate on this journey together, rather than me feeling like I'm already on the defense
Mm-hmm.
and having to defend my like decisions about their care.
Mm-hmm.
They are a willing participant in this with me. We're on this journey together. So I think that is actually pretty helpful. So if there's anything that I think that coming out of this conversation for me is at least advocacy can work
Yeah.
whenever you do that. And you just got to get past the fact that it sucks that you have to do that. But in many ways, like, that's what's going to save your life. In fact, there were so many patients there, like on my mom's floor and things, but they knew us, and they knew when they saw us coming, certain members. All right, we need to make sure. In fact, I remember walking into the to the room one time, and the woman handed me something, and I had completely forgotten that I'd asked for all her medication
Mm-hmm.
from the night before. Another
Yeah.
woman brought it to me, like, here you go, and we're doing this. And she stood up and she gave this report, and I was thinking, like, I understood like 5% of what you just said, but thank you for doing this, so I
Yeah.
can give this to the doctor who actually asked for it.
Mm-hmm. It's a
Hope
great
this
It's
makes
like
take home.
it's such a numbers game with what we
Yeah.
talked about, right? So I think about my family's own journey with finding healthcare with being self-employed and what's
Mm-hmm.
best for us and all this kind of stuff, and having to advocate for our own kids when we were told things were going to be paid for and they weren't, and us having to go down that rabbit trail.
Right.
And I'm talking about that from someone who might not even be experiencing the same bias
Mm-hmm.
that people of color would be, you know?
Mm-hmm.
And so there's so many layers to this. It's like, I'm glad we talked about that there is still hope, that there are people like yourself out there that want to kind of change the narrative around it, change
Right.
the approach, and kind of build something different from the ground up almost.
Most definitely. And I
Yeah.
think that's a good takeaway, your takeaway, humanizing, advocating,
Yeah.
but also that there is hope. You know what I mean? There are, as much as there are physicians and nurses leaving the profession, what is happening, there's a certain level of empowerment
Yeah.
happening too. Like, you know what? We're not going to accept this structure either
Yeah.
anymore.
Right.
And quite honestly, we probably need a little more of that, of individual physicians and nurses designing better solutions
Mhm.
to meet these needs that are so obvious.
Yeah.
Yeah.
So,
Yeah.
I will say this, that when despite the interaction that my mom had with that first doctor who discharged her, who it was very perfunctory and flippant about even seeing her, once we raised the issues of care, I mean, she had all died and stuff basically, so they kind of had like no choice but to, like it's a really bad situation. But once we raised that issue of the care, the hospital administration moved very quickly.
hmm,
They did. And so I do have to thank them and recognize the people that actually do go into action to go and do things. Now, whether that is because they're concerned about a lawsuit, probably bad PR, probably. But the reality is, at least they were responsive to that, and
yeah,
they got us in the position where we could feel more comfortable about her care until she was able to be like released from the
yeah,
facility, which is something that's really big, because before that wasn't happening. They were just kind of pushing her along, and so until we pushed that stop button and sound the alarm, they will listen to you. They are in our experience, they do.
And I should
Yeah.
say my brother has an A team. You know, that was kind of was one physician out of that team, but the same thing is like we're grateful for the care, and he's got a great team around him. So I also want to, with you saying that, take time and recognize those physicians on this team that have kind of gotten us to this point. So yeah, that's not lost on me either. You
Mhm.
know, one bad apple doesn't rule a bunch, if you will.
Yeah, and I will say though that bad apple though, I know, because there are certain professions where, maybe like the person who's making your sandwich at Subway, or
Yeah.
like your favorite deli shop, that can be a bad apple. If you suck at doing that,
Mm-hmm.
because the amount of harm. But
Yeah.
law enforcement, being
Yeah.
a pilot,
Yeah.
being a physician,
Oh
I
yeah.
just think they are high risk professions, and we need you to be accurate 100% of the
No,
time. We
I
need you to be
agree.
professional 100% of the time.
You know what?
Like,
I remember attending telling me when I was in residency, and it was my intern year, this attending who saw that maybe I wasn't, you know, as engaged and I need to be. And he said, and this has stuck with me and kind of governed how I doctor now, is that he's like, look, you may not know this now, but the conversations that you're having with these people may be the most important conversation that they're having in their life up to this point.
yeah.
Mhm.
And it stopped me in my tracks. And I looked around and I was like, he is right. Shout out Dr. Brown, Bill Brown. Um, and so, to his point, there are certain professions where we need the utmost professionalism
Mhm.
for you to be agnostic in a good way, right? For
Yeah.
you to always do the right thing. And I try to hold a certain level of professionalism,
Mm-hmm.
right, with that. So you're exactly right. It's one of those professions, even younger physicians that I train and med students, I always impress, like, hey, this is not where you wake up and have a bad day at work. Every day has to be a good day.
Yeah.
You
You know
need
what I
you to
mean?
win
Yeah.
every day.
Bad day at work for you is a little different.
Yes.
Yeah.
You know what I mean?
Yeah.
Like you have to have a good day.
Yeah.
So you're right. We need, there's certain structures that need to be held to a higher standard in healthcare. Physician, being a physician, rendering care, showing empathy,
Mm-hmm.
being on, if you will, and
Mhm.
showing care for another healthcare physician is definitely one of them.
Yeah.
For sure.
Doctor, what's next for you in GP Health?
You know what? We're going to continue to grow this thing because to our point, we think that we just need to reframe how we approach care. And so we're going to continue to grow the practice, but we're also going to continue to partner with civic, like-minded community organizations. Again, clinical care is probably 10% of this. So we like to, in some ways, think of ourselves as having societal or social impact. So we want to amplify that and grow that through different structures. So just continue to build that, continue to be a macro level advocate for better care. And just, I think what we're all seeking is just kind of continue happiness and fulfillment.
Yeah.
You know what I mean? Fulfillment that you left this a little better than what you found it.
Yeah.
And so that's me.
That.
Yeah.
Well, thank you for spending time with us today. I know that you're got a very busy schedule as your brand expands. Got some cool partnerships, prospects on the horizon. So we'll hopefully be seeing somewhere you really soon here in the DFW.
Most definitely.
But until then, I would love to toast.
Toast. That's a new one.
I'm a toast. I'm a toast to GP Health.
Yeah.
Yes.
And to advocacy.
Shout out to the team.
There we go.
Team GP Health. No one accomplishes anything alone.
That's it for today. Catch up on earlier episodes of At the Table wherever you choose to get your podcasts. And you can also watch full episodes on youtube.com/FitMenCook. And for daily inspiration, follow FitMen Cook on Instagram, Facebook, and Twitter. Until next time, keep it healthful, but never, ever boring. Boom.